So the study is about treating glioblastoma, a very, very aggressive brain tumor, with an extra shot of radiotherapy. We usually use external beam radiotherapy. That means the beam travels through healthy tissue to hit the tumor. That is done as standard of care. In INTRAGO, we're looking at a technique that's called intraoperative radiotherapy. That means we take the tumor out. You have a surgically exposed tumor bed, so to speak. And then you insert a irradiation source, a kind of a ball that emits radiation. And then you treat the tumor bed without the need of the rays having to pass healthy tissue. So INTRAGO is a classical phase 3 randomized clinical trial. That means patients either receive standard of care or they're randomized into an experimental arm that is standard of care plus intraoperative radiotherapy. We usually use randomization to exclude that one or the other feature would accumulate in one arm and then would skew the result. We try to balance both groups with equal characteristics by using randomization. Yeah, so the trial is still actively recruiting, and we're in a good path to be done with recruitment by the second quarter of next year, or even the first quarter of next year. And then we'll have to complete the follow-up period of another 2 years, and then we'll definitely report on this trial. One of the leading institutes that established IORT even in many diseases. You can use IORT basically from head to toe. Wherever you have a surgically exposed tumor bed and you expect that there are tumor cells remaining in the cavity, IORT may be a good thought. IORT basically combines two cancer treatments. It's surgery and it's radiotherapy. This can not be done in a daily fashion like conventional radiotherapy. So IORT in my institution, in most other institutions, is done as a single shot, a single high dose of radiotherapy to the tumor bed. Here at the Mannheim University Hospital, we use it for brain tumors within clinical trials. We use it for recurrent head and neck tumors that are mostly challenging to re-irradiate. And so where you can do a second surgery and then get the dose to the tumor bed easily with IORT. We use it in sarcoma. These tumors are very well known for being very infiltrative in nature, and that are usually associated with or maybe associated with local recurrence. There we give an extra shot. In sarcoma, we use it for breast cancer. That was basically the first indication when we acquired that system, where we treat early stage and low risk breast cancer with also sometimes with a single shot and then leave away external beam radiotherapy. And we use it for rectal cancer, mostly for recurrent rectal cancer. So when you have a pelvic wall recurrence or intrapelvic recurrence, it might be a good idea to use IORT. The multidisciplinary team is always involved. IORT is, in some diseases, it's a first-line treatment per guideline. So you have a tumor board. The tumor board says, hey, that specific patient might benefit from IORT added to standard of care, or sometimes some patients just get IORT and then we can skip external beam radiotherapy. It always involves a tumor board decision, but also in these challenging cases where you have, for example, rectal cancer recurrence. These patients are pre-treated with radiotherapy, with chemotherapy, and with surgery. And then they basically undergo the same treatments again. You have to be a good team, and specifically in the OR, when it comes to identification, where's the recurrence? Where do we still have positive margins, but can't resect any further? Where does the surgeon think there's tumor left, and how deep would that then be? So there, the multidisciplinary team is really asked to interact and to really find a region where IOT may add and benefit for a specific patient. We use one specific method that is soft X-ray IORT. So basically, there are two major established methods. One is to use electron IORT. That means you have a linear accelerator, and then you use fast electrons. You use these electrons that you direct to the tumor bed, and they have a also like soft X-rays. They have a very favorable dose depth profile. That means they can travel some centimeters, and then they're going to stop and pass along their energy into the tissue. That is pretty favorable. But these electron beams are forward beaming, and so they limit to cover, for example, cavities. And this is why we use soft X-rays. Soft X-rays come from a single source, a point source, and then travel in a circular fashion and create an isocentric irradiation profile. That means you kind of create a bowl profile of radiotherapy. And similar to electrons, these X-rays do not travel deep into tissue. They're mostly absorbed within few millimeters and centimeters. So that's, for us, that's a perfect setting. You have a spherical irradiation device, and the X-rays don't travel into the depth of the tissue. That's why we have decided to go for low energy X-ray or soft X-rays. And there are various vendors in both fields, electrons and soft X-rays. My advice would be that you think about situations where you have a patient that would otherwise not be able to get a second shot of radiotherapy, where a pre-existing, so to speak, radiotherapy would not allow you to apply a second shot. These could be cases for IOT. And there are many indications where you can really cut down the external beam time, or you can even skip external beam radiotherapy if you would consider IOT in the first place. There are some situations where I would say it has to be carefully checked within clinical trials. For example, malignant brain tumors. There I would strongly recommend also to join up and running trials. There's also some trials on brain mets now up and running, and there's going to be phase 3 trial in brain metastasis. These are the things where I could encourage everyone to look into that and maybe to join these clinical trial initiatives. But other than that, there's many guideline conformal situations where you can use and you should use IORT to lower the likelihood that a tumor would recur at the point where it initially was resected.